Good afternoon, everybody. I'm Kath Harrison. I'm a neonatologist from Leeds in the UK, and I'm the clinical lead of Scale Neonatology. I'd like to welcome you all to the Scale Neonatal Grand Round. This is an education collaborative between NHS Global Partners, West Yorkshire, LMNS and Uganda. And we are working through our series of grand rounds. We are talking about common neonatal conditions that we see worldwide. I'd like to welcome representatives from St Vincent and the Grenadines, from Montserrat and Ghana, who have joined us today to observe and to support the development of other Grand Round programmes with other global partner countries with West Yorkshire. So the format today follows our usual pattern. We've got two case presentations. We have one from Uganda, followed by about an update and current guidelines from Uganda about the management of chronic lung disease. And then we're going to hand over to the team from Leeds and West Yorkshire, who are also going to do a case presentation and an update of our guidelines and current evidence from the UK. So can I ask you all to please type in the chat as we go along any comments or questions, and myself and Kathy Burgoyne from Mbarara will try and answer your questions or comments, but we welcome lots of participation at the meeting. Could I ask you all just to put your mics on mute so it allows our speakers to do really nice, clear presentations. So I'd like to hand over to our first speakers. So we have Dr. Ivan from Mbarara and Dr. Stella from Mbarara, who are going to do a case presentation on chronic lung disease. So thank you very much, Ivan.
I'm Ivan Henry Kugonza, a pediatric resident at Mbarara University of Science and Technology, and I'm going to be taking you through the case presentation. I'm presenting AN, who was born on 19th of January 2025 and was admitted on that very day at 1 hour of life. She was born at 29 weeks of gestation by ANMP, and she stayed with us for 4 months, and he was under care by her next of kin, who was the mother, and they come from Kyoyagala district. Kyoyagala district is one of the neighboring districts, neighboring Mbarara district. So she presented with difficulty in breathing for 1 hour. And in the history of presenting complaints, she was admitted as a referral from a private clinic for neonatal care with difficulty in breathing, which started immediately after birth and progressively kept worsening in severity. This child was born from a very small clinic with no ability to offer newborn care, and she was delivered by SVD as a very preterm at 29 weeks with a very low birth weight of 1.27 kilograms with a good Apgar score of 8 at 5 minutes, and the baby did not require resuscitation. This followed a spontaneous onset of labor, which lasted about 8 hours with no history of fall or trauma, and there was no history of false maiden vaginal discharge prior to the labor onset. Upon birth, the child was rushed to Mbarara Regional Referral Hospital by her mother on a motorcycle, which is about 2.5 kilometers from the clinic for neonatal care. Still in the history, we note that this mother had a booking antenatal visit at 4 months of gestation, and she attended antenatal care 3 times. Important to note, 3 weeks and a half prior to delivery, she was admitted for 3 days and managed for severe malaria from a remote clinic in a single district where she works from. She reported to have attended antenatal care, and she had received all the packages, and she sleeps under a mosquito net, and she had a negative test for syphilis and HIV. There was no reported history of, she had no history of gestational hypertension, gestational diabetes, but we noted that she did not receive corticosteroids prior to delivery. This mother was 19 years old, now a para 1+0, who is an artist by profession and who does decoration in a single district where she reported that she does not receive any support from her husband. So on exam, we noted we noted a small preemie who was in respiratory distress with acrocyanosis, hypothermic, with no obvious features of dysmorphism, and she had no skin rashes. And her weight was 1.27 kilograms, hypothermic with a temperature of 35.0 degrees centigrade, and a pulse rate of 155 beats per minute, and she was tachypneic with a respiratory rate of 76 breaths per minute and SpO2 of 76% on room air, and she had a normal random blood sugar of 3.2 millimole per deciliter. Child was not pale, was not jaundiced, and had no palpable lymph nodes. Respiratory system, she was tachypneic in moderate distress with a Silverman-Anderson score of 6 out of 10, with equal air entry bilaterally with normal breath sounds. And in the cardiovascular system, she had a capillary fill time of less than 2 seconds, which was normal, with a normal volume regular pulse and normal heart sounds 1 and 2 with no added sounds. There were no murmurs. And her abdomen, the abdomen was of normal fullness. The cord was well ligated with a normal female genitalia and no palpable masses, no palpable organs. And in the central nervous system, she had a head circumference of 28.3 centimeters, which was normal for age, with a normal tensive fontanelle, and they had a suture diastasis with no scalp swellings. So we made a diagnosis of very preterm with very low birth weight, with moderate RDS and hypothermia, and the management that was done at admission. We started her on bubble CPAP. This is manual bubble CPAP at a PEEP of 7 centimeters of water, and the oxygen was non-blended. We provided warmth by radiant warmer, also gave prophylactic antibiotics for 5 days. That was ampicillin and gentamicin. We also administered vitamin K, 0.5 milligrams. We noted that the baby had not received vitamin K from the delivery unit. We also started her on neonatal feeds. We gave dextrose 10% at 80 ml per kg per 24 hours. We gave caffeine for prophylaxis for apnea of prematurity. We monitored vitals, then baby was transferred to the neonatal intensive care unit. Then in the first week of life, baby was doing well, was weaned off from CPAP on day 6 of life, changed to free flow, and was getting antibiotics still, was still on caffeine, and was tolerating the neonatal feeds, the trophic feeds that were started on day 2 of life. In the first months of life, while in the NICU, baby attained full EBM of 160 ml per kg per 24 hours on day 9 of life, and was transferred to stable preterm on day 10. So later, baby desaturated when he was in stable preterm and was transferred back to NICU for oxygen. That was on day 12. And also baby developed the jaundice. That was on day 17, which was managed by phototherapy. And the child also developed the late onset neonatal sepsis on day 18, which was managed with cefotaxime for 7 days. Anemia of prematurity also set in on day 18, and the child got top-up blood transfusion with packed blood cells at 15 ml per kg. And also kangaroo mother care was started, but we noted that the child developed the extrauterine growth restriction. The child had a weight of 1.15 kilograms on day 30 of life, yet actually he was born with 1.27 kilograms. It was still on oxygen in the first month of life. In the second month of life, the child developed a second episode of late onset neonatal sepsis. This was Klebsiella pneumoniae, which was confirmed by blood cultures, and the child was managed with meropenem for 14 days, and the child improved, but was still on oxygen, 0.5 liters per minute, and also at this time, the child had better weight gains. In the third month of life, baby was in stable preterm on kangaroo, was off oxygen, was gaining weight, and was tolerating all the cup feeds, and we had also started breast attachment. There were no new concerns, and the baby was discharged on day 85 of life with a weight of 2.1 kilograms. So this slide shows the weight trends, how weight kept moving from the time of birth, you realize was born with a weight of 1.27 kilograms, then you can follow the trend and see how there was slow weight gains continuously. This slide shows us temperature trends from the time child was admitted. We noted the child was admitted with a temperature of 35.0, that was hypothermia, but later on temperatures normalized, temperatures were stabilized actually. Temperatures were within normal range of 36.5 to 37.5. This was good. So in the follow-up, 10 days after discharge, the child was readmitted with 1 week history of worsening difficulty in breathing, which was associated with dry cough, fast breathing, noisy breathing, and mild fevers. This was also associated with reduced feeding. So other systems, the GIT, the cardiovascular system, and the central nervous system plus the genital nervous system were really unremarkable. And on exam, when she came back, we noted a sick-looking infant in severe respiratory distress, and child was wasted, warm to touch, irritable with moderate pallor, not jaundiced, and was not cyanosed, and had no edema. Had a temperature of 38.0 degrees centigrade, which was high, and was tachycardic with a pulse of 185 beats per minute, tachypneic with a respiratory rate of 70 beats per minute, and was desaturating at 79% on room air. When we did the anthropometry, we noted that her weight for age was below the 3rd percentile, and the head circumference 34, this was normal at the 50th percentile, and also the length was normal for age, and these were plotted on the Fenton chart. Yes. And the respiratory system, child was tachypneic with severe respiratory distress, with nasal flaring, intercostal recessions. However, had symmetrical chest movements with the bilateral crackles and occasional rhonchi in both lung fields. And the cardiovascular system, the child had warm peripheries with an apex beat of in the fourth intercostal space mid-clavicular line and normal heart sounds. And in the CNS, child was irritable. The neck was soft with no focal neurological deficits. And per abdomen, the child had a slightly scaphoid abdomen with no organomegalies, with normal bowel sounds. We had our problem list. And here, number 1 was severe respiratory distress, severe wasting. This is the extrauterine growth restriction with moderate anemia. And we made an impression of bronchopulmonary dysplasia, which is also called chronic lung disease of prematurity, with bronchopneumonia, querying possibly viral pneumonia. So I also had anemia plus the severe acute malnutrition. So in our plan of care, we did a complete blood count together with a chest X-ray. And on the chest X-ray, we saw an emphysematous areas. These are common in bronchopulmonary dysplasia patients. We supported the child with oxygen. We started the child on IV antibiotics. Initially, we started with X-pen and ceftriaxone, but child was not improving. Then we started meropenem, and the child improved. We also did nutritional counseling and support. Also transfused with packed red blood cells. Next slide. So still in the follow-up, we see the complete blood count that was done. Importantly, that was there, we had a moderate anemia, normocytic of 7.8 grams per deciliter. The white cell counts were normal with normal differentials. Child was weaned off from oxygen daily prior to discharge, and the child was discharged after 1 month of hospital stay. And the plan was to the child to be followed up in the newborn and nutritional clinics. Thank you very much.
Thanks very much, Ivan. That was a really clear and very thorough, detailed presentation. And I think you described many of the comorbidities that we see for chronic lung disease requiring different treatment strategies. So that was really good. Thanks so much. I would like to welcome Dr. Stella, a lecturer and paediatrician from Mbarara, and she's going to talk a little bit more about chronic lung disease, the condition, and how we and how it presents with some complications. So thanks very much, Stella.
Thank you so much, and greetings to everyone. We are in different time zones, and thank you, Dr. Ivan, for such a great presentation of our patient, who is still alive and with us in our newborn clinic. So that's what I'll be looking at. We'll be looking at some few definitions and factors influencing the pathophysiology and some clinical presentation, and then later complications. So chronic lung disease, in simple terms, is a condition where there is injury to developing lungs, which are usually premature. And after this injury, there is impaired healing. And as this impaired healing takes place, it compromises the normal development in the third trimester that is supposed to take place in the third trimester or later. And so as a result, there is compromise to the functions of the lungs and a lot of predisposition to many other problems like we will see. So you have literally injury and then impaired healing, but usually to premature lungs. And it was discovered in 1967 and is a chronic injury, mostly to premature lungs needing oxygen, and characteristically, it's defined by constant or prolonged need for oxygen beyond 28 days, and for some places they will tell you for more than 36 weeks for prematures who are born way below 36 weeks, as we'll see in the definitions. It was initially a severe form. It used to be very severe, and I guess right now, if we have adult survivors of the initial forms of chronic lung disease, they must be suffering a lot of complications. And that was because of the initial interventions that were available for managing respiratory distress syndrome in prematures, using a bit of more rigid ventilators and with high pressures, and that caused more lung injury. And so the patients then healed with a lot of injuries to their lungs and had persistent respiratory failure, and they stayed on oxygen even for longer. And then hypoxia, they would get corporal pulmonary and emphysema with a lot of atelectasis mixed up with emphysema. And after changing in interventions for newborn care, we got a bit of less injury to the lungs because this was noted, and of course a lot of interventions were made to improve care and have better outcomes, not only survival. In the beginning it was about survival, but now the babies have to survive and thrive. So there were modifications in care, in the equipment we are using, and also other interventions like caffeine, surfactant, and early initiation of CPAP saved many babies from going on to ventilators. So we have the milder form of chronic lung disease, where these changes are not so bad. The emphysema is not really like extreme, as well as the atelectasis. So the prevalence varies from place to place, and but when you look at the small babies that we are talking about, mostly very extreme preterms who are less than 28 weeks, it actually goes all the way from 40 to 60, some places 48 to 68. And that is high. We may not even be aware of it in some of our places like Uganda, because other than seeing these daily clinical cases that we see as we manage patients, we do not have a clear documentation of how many are actually suffering this chronic lung disease, but also the definitions. Different places take on different definitions for chronic lung disease. So we are moving away from that to have more consistent data, and probably more research in other places as well to have better information about the prevalence. In Mbarara, chronic lung disease is there, but we tend to recognize mostly the severe, moderate to severe forms of chronic lung disease. And I think in many places, the mild forms that are not on oxygen end up being missed, and yet they are there. And they need to be followed up and be monitored for all these later complications. So because we rely on the clinical signs most of the time, and we rarely have to do x-rays for every preterm or those who have stayed on oxygen for long, we miss out some of these cases. But here in the moderate to severe forms, we see at least one case in 1 to 2 cases per month of the moderate to severe forms of chronic lung disease. Definitions, we have the NIH definition that was developed in 2001 to kind of guide on having a more agreed consensus on the definition of chronic lung disease. And this was good because it helped to classify these children into the different severities for you to be able to predict those who are likely going to have the more severe forms and who should be kept under monitoring even when they've been discharged home. So for babies who are less than 32, if assessment is done who are born at less than 32 weeks, if assessment is done at 36 weeks postmenstrual age, it means that the mild cases of BPD will be those ones who are actually breathing at room air, but they may have some radiological changes by 36 weeks. And then the moderate ones will still be requiring oxygen supplementation, but usually low FiO2 of less than 30%. And most of the time they won't actually be they will not be on mechanical ventilators and CPAP. And then those with severe BPD will be those ones who are requiring a higher FiO2 of more than 30%. They are mostly on CPAP or mechanical ventilation by that time. And so for those who are more than 32 weeks, who are born more than 32 weeks, assessment as well at more than 28 days of life and less than 56 will have similar findings, okay, as the ones who are below 32 weeks. But this doesn't mean that you cannot diagnose chronic lung disease before 36 weeks postmenstrual age or before 28 weeks, because there are risk scores that can be used, but also if you image these babies early, you'll be able to see these changes and you can do your interventions early to kind of prevent worse progression. And then the physiological definition, this one was put in place in 2004. And this was aimed at not just having rigid cutoffs, but for you to progressively assess your baby to see if they would be having, they could potentially be having chronic lung disease. And yes, if assessment is done at 36 weeks, which is usually between 35 and 37 weeks, there was it is a test where you attempt to wean off these babies from oxygen. So infants treated with mechanical ventilation, CPAP or supplement oxygen concentrations of more than 30 at that 36 weeks or are getting oxygen saturations of 90 to 96 were automatically diagnosed with BPD. Reason being that you're already on CPAP, you're still on mechanical vent, you're already at 36 weeks postmenstrual age, and your SATs are still 90 to 96, then you definitely have chronic lung disease. But for those who are getting supplement oxygen of less than 30%, FiO2 of less than 30%, with oxygen saturations of 90 to 96, or those who have who are on supplemental oxygen of less than 30%. So these were put to a test where they will be progressively weaned off oxygen to see their response to this weaning off of oxygen. And so those infants who are receiving oxygen, for us, we don't use oxygen hoods. We use the nasal cannulas more. But those who are using oxygen hoods, they would reduce the oxygen by 2%. Whereas if you're using a nasal cannula and your flow rate was already 1 to 2, which is high flow for preterms, then we would step down by 0.5 liters per minute, and we monitor your saturation and we see how you respond. Okay, but in case your sats were already below 1 liter, then they would step down by 0.1 liter per minute to see how you respond. So those who manage to reduce and go to the lowest and they are still stable, and they actually allow to go off oxygen without desaturating, were not considered to have chronic lung disease. Whereas those who failed to wean off oxygen or desaturated once that the reductions in oxygen were being made, then were considered to have chronic lung disease. And I think this is a bit of a more physiological assessment of how your lungs are responding to oxygen therapy. So what are some of these factors that influence the development of chronic lung disease? To start with, the beginning factor is usually a premature lung, and that will be found in our extreme preterms. And that the difference about the extreme preterms is that before 28 weeks, they are having less number of alveoli, so their surface area for gaseous exchange is very minimal. Then they are having very friable blood vessels going through, and then their epithelium is not having well-developed pneumocytes, type 1 and type 2 pneumocytes. And so they are really fragile lungs. And so in antenatal, if you get factors like intrauterine growth restriction, placental dysfunction, chorioamnionitis, usually which is secondary to infections and PPROM, and then bacterial colonization of the mother during antenatal. These can be urinary tract infections. It can even be, like frank sepsis in a mother who is pregnant. And then maternal hypertensive disorders, both preeclampsia and underlying hypertension, which is not controlled. And then maternal smoking and baby's genetic predisposition. These babies also have a genetic predisposition. Those who tend to develop BPD, some of them have a prior genetic predisposition where their lung development and healing is not as good as the rest. So these factors actually interfere with appropriate lung development beyond 28 weeks and going forwards. And with that, they increase the risk of developing chronic lung disease. Then also if a baby, some babies are born without even any of these risk factors, but when they are born, they are really too small, they are having severe RDS, they need mechanical ventilation, and they need supplemental oxygen, and also sometimes they develop infections like you've seen in our baby, got 2 episodes of hospital-acquired sepsis. That was unfair for that baby. But that's sometimes what happens if you don't maintain maximum IPC in NICUs. And so these infections, whether they are systemic or pulmonary infections, they actually injure the lungs. They increase inflammation in the lungs and injure the lungs further, which will lead to later impaired healing. And then ventilator-induced injury, this one is usually due to high ventilator pressures, airway pressures that are set on the machine, and prolonged applied pressure during the inspiratory phases, and also aggressive bagging. Sometimes we are too aggressive, we bag preterms and we want to see their chests rise and really rise out there. And sometimes if you're not regulating these pressures, you can actually injure the lungs more. And prolonged oxygen exposure to the lungs actually causes direct injury to the lungs compared to the other tissues, because the lungs are directly receiving this oxygen. So it is said that if you have this oxygen exposure and it is for long times, for longer periods, it doesn't matter whether the baby is saturating well or poorly, or you're having other interventions. These babies do not have the mechanisms to offset this oxygen exposure and the oxygen free radicals compared to term babies. So they are likely going to suffer these effects. Like you said, in our baby, she was on oxygen for 2 good months. And that was really a prolonged period of oxygen exposure. Then the patent ductus arteriosus usually increases pulmonary blood flow, and these increased pressures to the lungs cause more damage and sometimes are also associated with pulmonary edema and pulmonary hypertension. And this will cause more injury to the lungs. And so what all those factors do is that they are going to cause further injury to these premature lungs. And like I said, as a result, you have inflammation, you have impairment of alveolization, that is further bifurcation of the alveoli to create more, and a lot of edema in the lungs and inflammatory cytokines and all that. And then as the lungs are healing, they will get more fibrosis, and that will cause more respiratory failure. So much as you would want to remove this baby from oxygen, if they are having just a few alveoli, they won't survive without oxygen. This is more or less the same as we've been talking about, and I hope that it is clear to everyone. I wouldn't want to take more time on this. So looking at the major factors that influence development of BPD, the first one is prematurity, like we've said. Premature lung is fragile, less alveoli, immature epithelium, and no surfactant or very little surfactant. So this is a lung which is already compromised at birth. And then when you come to the mechanical trauma from ventilation, from mechanical high pressures of mechanical CPAP, some people accidentally give people of 9 centimeters of water to a small baby. And sometimes you're also having bagging for babies who are having apnea, and people are bagging a lot. So these cause mechanical injury and also lung overdistension. That initial lung overdistension impairs the recovery of this lung. And also high inspiratory pressures, like I said. If we are setting our machines, we should be modest with the pressures we give to these babies, as well as the tidal volumes. And then it's also seen that the ETTs for babies who will definitely require ventilation also impair drainage of the secretions from the lungs, and these increase lung infections to these babies. And then the oxygen toxicity. Oxygen is good, but we always need to remember that it's a drug and it has side effects. It causes direct lung injury for babies who are on high FiO2 or babies who will require prolonged oxygen therapy. And it causes also vascular endothelial damage. It damages the endothelium, which is supposed to be the surface for gaseous exchange. And as well, injury to the type 2 and type 1 pneumocytes, which are supposed to be helping in recovery with production of surfactant, so that is well used. But also they impair the movement of the cilia within the respiratory system, and so that these babies cannot expectorate and remove these secretions with ease. And as well, excessive oxygen administration will inactivate surfactant, and so you have more dependent babies and free oxygen radicals. Infections and inflammation, this cause direct injury to the lungs, but also they can result in bronchoconstriction, and this bronchoconstriction can reduce the lumen of the bronchioles and the bronchi, and this will impair on expression for air to get out. So as more air is entering, it will be trapped and it will cause more emphysematous changes in the baby's lungs. And we've already talked about the PDA and pulmonary edema. So it's always good for us to keep checking for PDA in babies who are having mamas, so that we do early intervention of management of PDA. At least we do that at Mbarara, and we've had a high success rate with treatment with our NSAIDs. And then clinical presentation. Initially, these are very small preterm babies with risk factors in antenatal. Like you saw our baby, malaria is one of those infections in antenatal that could increase the risk of BPD because it's associated with high inflammatory reactions. And so you have antenatal risk factors, maybe rupture of membranes, chorioamnionitis, and no antenatal steroids, as you saw. This mother went to the clinic 2 times, and at both times, no steroids were given to her, yet she was high risk for preterm birth. And then they are born small, and then they will have, some of them will have severe RDS, others will not have even severe RDS, but will require oxygen. And then ideally babies with RDS, by end of first week, they should have started improving, because by day 5, they are starting to make their own surfactant, if all the conditions are maintained neutral. So unfortunately for babies with BPD, they end up getting even worse, yet they are supposed to be improving. So you're going end of first week, they are worsening. Second week, they are having more oxygen requirements. Such babies are likely developing BPD. And then the classical presentation is a high respiratory rate, like we say in our baby. And then chest exam may reveal also some wheezes in some babies, although for some babies, you may not really pick much, but they may have also reduced breath sounds. And then tachycardia, because babies compensate to hypoxia initially with tachycardia as they're increasing their respiratory rate. And then they can have signs of right-sided heart failure when they are developing pulmonary hypertension from all these increased pulmonary pressures. So they will have cardiomegaly, hepatomegaly, and fluid retention, and increased work of breathing, grunting, chest indrawing, nasal flaring. As you saw, baby had an increased SARS score. So also these babies have frequent desaturations. Every time they're on oxygen, they seem to be doing so perfectly well. But the moment you take them off oxygen, a few minutes later, they will start desaturating, and they tend to only be okay when they are having oxygen. It doesn't matter whether it is 0.1 liters per minute, they will actually do well on oxygen, but not without oxygen. And because of the increased work, they will tend to lose weight faster, and they will have, in the initial phases when they are having established BPD, they will have increased need for respiratory support. And some of them end up on ventilators because they fail on mechanical CPAP. So what do we see in their x-rays, in their lungs? So in the severe forms, you will see what is, I hope I can be helped with a cursor, but you will see what is seen on this dark x-ray. It is on my left, okay? Yeah, that one. You will see emphysematous changes. Those pockets of dark areas in the lungs that you're seeing are actually areas of air trapping. Air has been trapped, and around it there is healing with fibrosis, so they are nicely well demarcated. But also sometimes they get areas of atelectasis where the lungs, due to the blockage of these airways or a lot of inflammation, their alveoli end up collapsing, and you will not have any air going in those lungs. So sometimes this mix, you have some patches of emphysema and other patches of hyperdensity, okay? And then in the other x-ray, which is on my right, is actually the milder form, where you won't see obvious emphysematous changes, but also their x-rays much whiter due to chronic inflammation and a bit of fibrosis, but not obvious emphysematous and collapsed areas compared to the severe forms. So sometimes you will even find the x-ray is not having any significant changes. What happens later, as these children are growing up, the lung changes also continue. And these emphysematous changes, as you can see, that a lot of darkening and sometimes collapse that will happen in their lungs from 6 months to 14 months to 23 months. And these children then will be at risk of getting chronic lung disorders, especially the obstructive lung diseases. So pathologically, this is what it looks like. You will have those blebs or swellings where there is emphysema, and there will be interlocked in areas where lungs have collapsed and your lung volume is very small. So I've always had people asking me, but when are we taking this baby off oxygen? Because we don't discharge our babies with oxygen cylinders home. It's not yet possible here. So sometimes when you're working with such a lung, you really can't force the baby to get off oxygen, because its ability, its capacity to have good gaseous exchange is still impaired. So what happens other than the lung changes? What happens later in life to these babies? Yes, you will have actually the true lung changes will predispose these babies to more pulmonary infections, and these infections tend to be severe, and they tend to require prolonged treatment. Like you can see what our baby had with severe forms of chronic lung disease. She got a severe episode of pneumonia just 10 days after discharge, and took a whole month being managed for the same. And then they will have impaired exercise intolerance, because as you're doing exercises, you need more oxygen to sustain you, but they go into acidosis faster, and they cannot keep up with exercises. And then they are at risk of developing pulmonary hypertension, and some of them will require treatment for pulmonary hypertension. And then you have increased risk for cerebral palsy. Now, these are the other complications other than the pulmonary ones. There's a prospective study that was done and followed up these children for 12 years. And they found a significant number of these children, I think it was about 12%, had developed cerebral palsy and had developmental delays. And then about 40% of them had lower IQs and impaired executive functioning, like quick math numbers and all that. And then behavior changes and delay in expression and receptive language. So all the cause of development tend to be affected in these children. And then increased risk of growth failure. And then, of course, retinopathy and vision impairment. Retinopathy of prematurity is a risk, because one, you're going to give a lot of oxygen for long, but also they're at risk of going into hypoxic episodes. That will also cause retinopathy of prematurity. And then BPD survivors have higher rates of healthcare use. Like we say in our baby, it was less than even a month of going home, and she's already back in hospital. And starting with initial hospitalization, prolonged follow-up, because they are at risk of longer issues. So you need to retain them in clinics for long. And also when they get their conditions related to chronic lung disease, like we saw, they are usually severe and will have to incur expensive medical bills. So that is it. Thank you so much.
Thank you so much, Dr. Stella. That was a fantastic and thorough overview of chronic lung disease, how to make the diagnosis, and just a really simplified way for us all to understand the pathophysiology and the long-term effects. So thank you very much. So just a reminder, everyone, you can keep posting your questions or any comments in the chat as we go along. Now I'd like to hand over to our next team of presenters, who are from Leeds in West Yorkshire in the UK. And we've got our case presentations being done by Jenny Naylor, who is an advanced nurse practitioner on the neonatal unit. And then I'll hand over to Georgina, who's one of our neonatal trainees, who's going to talk a little bit further about some of the recent evidence about how to manage chronic lung disease. So thank you, Team Leeds. I'm going to hand over to you.
Thank you. I'll just share the presentation. Thank you to Avan and Stella for your great presentation as well. So as Kath introduced, my name's Jenny. I'm one of the nurse practitioners here in Leeds, and I've got Georgina, one of our registrars, alongside me as well. So I'm just going to firstly talk about some medical history for our case. So the maternal history was a 28-year-old lady who was previously fit and well. This was her first pregnancy with normal antenatal scans. She then attended the maternity ward at 25 weeks pregnant, presenting with a E. coli urinary tract infection. This was then followed by spontaneous premature labour. Before the labour, the baby had 2 doses of antenatal steroids and magnesium sulfate. So at 25 plus 1 weeks gestation, the baby was born via a normal vaginal delivery and was born in reasonable condition, however did need intubating at a couple of minutes of age, where they received surfactant via the ET tube. From that point forward, they were then brought to the neonatal unit and remained on the ventilator until they were 24 days old. They had 2 unsuccessful extubations at 2 days of life and then again at 4 days of life, and then just remained intubated and ventilated until 24 days. Following that, they were extubated to some BiPAP, which was then reduced to CPAP, and then some high flow oxygen for the next 8 weeks, and then onto some low flow oxygen from around 37 weeks gestation. And the baby is currently still an inpatient, remaining on low flow oxygen. So the presenting complaint focuses on the chronic lung disease, is that the infant was ventilated for 24 days. As I said, they'd had 2 unsuccessful extubations and had ongoing requirements of oxygen at over 36 weeks gestation, which is a indication of chronic lung disease. And other issues that we just want to highlight is this baby had a PDA, which was closed by 38 weeks gestation. Throughout their stay on the neonatal unit, they have had lots of investigations. The key ones are the radiology investigations, which are chest x-rays. They had multiple chest x-rays since birth, initially with some RDS appearances and then changes to chronic lung disease as the age progresses, which I'll discuss shortly. On echocardiogram, they had their PDA. This was a large PDA at 3 millimeters with some ductal steel. They had cranial ultrasounds, which were normal on final cranial ultrasound as per our protocol. This infant had ROP injections at 35 weeks and had lots of bloods taken throughout their stay, had multiple infection screens, all which were short courses of antibiotics. However, at around 33 weeks gestation, this baby did get treated for a 5-day course of antibiotics for a raise in their CRP and a clinical deterioration. And there were ongoing monitoring of electrolytes and brom profiles as well. So just to quickly look at their x-rays, you can see the one on the left-hand side is the initial x-ray on admission, which shows ground glass appearance of RDS. And as I said, this baby did receive 1 dose of surfactant. And then on the right-hand side is a more recent chest x-ray, which shows the cystic changes and the more coarse interstitial markings of the chronic lung disease as time has progressed. So the management from the chronic lung disease, the baby received steroids. Steroids were commenced at when the baby was 20 days old, and they received steroids for a total of 20 days on a daily dose, and then they progressed to having 12 days of alternate days, so a weaning dose of steroids. So they had a total of 32 days of steroids, which was dexamethasone. The baby has had and continues on diuretics. They were commenced at 34 days old. They were initially IV diuretics, and then as the baby progressed onto feeds, they have changed to enteral diuretics of chlorothiazide and spironolactone. For treatment of the PDA, they received both paracetamol and PDA closure. Paracetamol was commenced at 11 days old, and subsequent echoes showed that the PDA remained opened and not closing, so they escalated to ibuprofen. And the latest echo at 38 weeks shows that the PDA has now closed. We're just going to quickly discuss the nutrition and growth of this infant. So as well as the respiratory concerns requiring ongoing non-invasive support and the early intubation, the baby also had ongoing concerns with nutrition and growth. They had difficulties reaching full feeds, and this was due to severe reflux. This baby was born, as I said, at 25 weeks, and they did not reach and continue on full feeds until 36 weeks. So it was a long period where this baby did not receive optimal nutrition. They kept starting feeds, and then the feeds would be stopped due to the severe reflux, which was causing respiratory symptoms. Eventually, the baby did end up on continuous feeds of fortified EBM, and that was via nasogastric tube. To treat the reflux, they are on erythromycin and then escalated to omeprazole additionally. You can see that the lack of feeds has resulted in poor weight gain, as the baby's initial birth weight was on the 25th percentile, but the current weight has dropped to the 0.4th percentile. To try and aid weight gain, collagen has been added to feeds to give extra calories. And also, the baby had quite severe hyponatremia, and so commenced on sodium supplements which were increased in line with ongoing blood monitoring.
I'm going to take over now and talk through the management. So my name's Georgina. I'm one of the neonatal doctors here in Leeds. So to begin with, we've already been through definitions of chronic lung disease. Thank you very much to Dr. Ivan and Dr. Stella, and to Jenny as well. So there's varied definitions of chronic lung disease that have changed over time. And I just wanted to mention our current UK definition as per BAPM, which is the British Association of Perinatal Medicine, who write a lot of our guidelines and frameworks for practice. They've recommended the use of a guideline of a requirement of respiratory support at 36 weeks corrected gestational age in an infant born before 32 weeks. And that's what our all our data collection is based on, and our guidelines are then based on that definition. We know that chronic lung disease impacts well beyond the neonatal unit and into childhood, and is a cause of a significant number of unplanned PICU admissions and rehospitalizations. And it's the neonatal outcome which is most strongly associated with a lower IQ than any other comorbidity. So we know it's something that we really need to try and improve where we can. And a diagnosis of chronic lung disease or bronchopulmonary dysplasia is associated with a reduction in IQ by 1 standard deviation. So to begin with, I just want to talk through the BAPM toolkit for prevention and treatment of chronic lung disease. So the toolkit breaks the approach to managing chronic lung disease down into 5 core elements. So the first of those is perinatal optimization. So that's looking at place of birth, making sure that babies are born in the right hospital and that our extremely preterm babies are born in a unit which is used to providing tertiary level neonatal care. It also includes ensuring antenatal steroids are given and a full course is given. It also includes optimal cord management and ensuring delayed cord clamping and good thermoregulation care. And although some of those elements aren't necessarily directly causal to the reduction in chronic lung disease, we know that they increase survival, and they do have an impact on our survival rates and morbidity as well. So the second core element is early respiratory support, so ensuring that we're paying close attention to gentle lung aeration at delivery, and ongoing attention and close attention to the pressures delivered. So that's both in the delivery room and following admission to the neonatal unit, ensuring the lowest pressures, the pressures are reduced when appropriate, so that we're using the lowest pressures required to deliver respiratory support to that baby, or if they're on non-invasive support, ensuring that we do maintain the PEEP, and that requires really, really good nursing care and close attention to making sure the mask is fitting correctly. And actually, there's a huge amount we can do to prevent chronic lung disease developing with really good nursing care, and ensuring good delivery of CPAP and non-invasive ventilation. It also involves ensuring surfactant is delivered where appropriate, ideally via a minimally invasive technique, or via a technique that is where there is local experience. And if the baby is requiring ventilation, ensuring that is volume guided to begin with, unless there's a clear reason not to, and just really making sure that we strive to deliver volume guided ventilation and don't take off the volume guided and put under pressure support unless there's a really clear reason. And actually, if volume guided is not working, then to consider high frequency oscillation as an alternative. So then moving on to section 3, so optimizing care of sort of the other organs which can positively impact respiratory outcomes. So that's including things like ensuring early maternal breast milk, and targeting that as an area for improvement, ensuring that there is a targeted approach to PDA management, which I will talk about more in a moment, and ensuring we're doing what we can to prevent early onset or late onset sepsis. The next section of their framework is the pharmacological interventions. So that's looking at caffeine, postnatal steroids. So that includes dexamethasone, which I'll talk more about in a moment, but also early hydrocortisone, as per the Premilock study, and also considering diuretics. Then the final core element that VAPA recommend is close attention to detail to the wider multidisciplinary teams. So just emphasising the importance really of all the different teams involved in the baby's care. So the dietitians ensure ideally a weekly nutritional ward round for these babies, close liaison with our respiratory paediatrician colleagues and ENT, physiotherapy from an early age, speech and language therapy involvement, and most importantly, really seeing the parents as partners in care and making sure that they are involved in their baby's care and the decision making. And we know that there's good evidence that that reduces neonatal stay. So that this next slide summarizes all of that and just emphasizes that there is no one-fits-all approach to reducing bronchopulmonary dysplasia or chronic lung disease, but actually you can look in each local unit and consider targeting any of those areas as quality improvement and areas for improvement, and different things will be right for different units in order of how best to make improvements. So I'm going to now talk about more of the pharmacological treatments for chronic lung disease. But I hope so far I've emphasised that actually the pharmacological treatment is only a small area of management of chronic lung disease. So firstly, diuretics we consider as within the management. So we would consider our Leeds guideline, we would consider diuretics if the baby is in more than 40% oxygen and is ventilator dependent and has characteristic chest x-ray findings of really very wet lungs with evidence of pulmonary edema. In that situation, we would definitely be considering diuretics. We would initially IV use furosemide and then spironolactone orally, or potassium canrenoate if it is the IV equivalent of spironolactone. And once tolerating enteral feeds, we would change the furosemide to chlorothiazide. We try to avoid furosemide ideally in the first week or two of life because that can stimulate prostaglandin production and delay the duct closure. And again, we would change to chlorothiazide due to reduce the risk of side effects, which I will talk about in a moment. In terms of when to stop diuretics, the most important thing is watching the baby.
Seriously.
Look for any clinical benefits. So if there is a clear clinical benefit, then the diuretic should be continued for 4 weeks, or until they have been in air for more than 1 week. We need to monitor the sodium levels, and if there is no benefit or a deterioration, we would either stop the diuretics and or consider corticosteroids. If there's a deterioration after stopping the diuretics, our guideline would recommend continuing them for a further 4 weeks. In terms of side effects of the diuretics, hyponatremia is a common side effect, so we need to monitor the electrolytes closely, and we would say check the sodium and using these within 48 hours of starting diuretics, and then regularly until the sodium is stable, and we may need to start sodium supplements. We know that nephrocalcinosis, which is what's shown on the ultrasound in this picture, can be caused by loop diuretics, and although it does often resolve, there can be a deterioration in renal function, so that should be monitored along with the calcium and phosphate, and they may need referral to renal going forwards. Diuretics can also be associated with poor growth, so all of this has to be balanced in the overall management of the baby. So dexamethasone is one of the common treatments for chronic lung disease. So there are different approaches across the world and across the UK. Within our unit, we use a regime called Minidex and or Maxidex, but there are other regimes which I will talk about. One of the key things to say is not to start dexamethasone in the first 7 days of life for chronic lung disease. There's evidence that that increases the risk of spontaneous intestinal perforation, which is why I've just put that X-ray up showing obvious pneumoperitoneum, possibly due to spontaneous intestinal perforation. So we avoid dexamethasone in the first 7 days. But after the first 7 days, although usually after the first 14 days of life, it can be considered if there are ongoing high ventilatory requirements which are not related to infection or a PDA, and if there are chest X-ray changes consistent with chronic lung disease, and ongoing deterioration is likely if treatment is withheld. So in Leeds, we use Minidex, which is one of the lower dose regimes, around 50 micrograms per kilo per dose for 10 days, and then we move to alternate day dosing. We wouldn't give PPI cover if they're tolerating feeds, and we would assess the risk if they were not tolerating feeds, but bearing in mind that PPIs are modifiable risk factors for NEC in themselves, so they should only be started with a careful consideration of the risks and benefits. Maxidex we use if there is no response to Minidex after 4 days. So that's a higher dose at 200 micrograms per kilo per dose, 12 hourly, and then a tapering dose going forwards. DART, which stands for dexamethasone, a randomized trial, is the most heavily studied protocol for giving dexamethasone in the UK, and it is the most commonly used regimen. It is a lower dose dexamethasone, although it is actually slightly higher dose than our Minidex regime that we use in Leeds. And this was a multi-center international randomized control trial that showed that low dose dexamethasone used systemically after the first week of life facilitates extubation and shortens the duration of intubation among ventilator dependent preterm infants without any obvious short-term complications. So that is a regime that is used commonly across the UK. In terms of PDA management, so this is another area that is really important when managing chronic lung disease, and an area with lots of controversy, and different consultants within the same unit do different things, and different units across the country do different things, and I'm sure internationally lots of different things are done. There's lots of randomized control trials showing different things, and I've tried in the next few slides to just sort of summarize some of the evidence out there, but I think the overall thing is that we don't really know how best to manage them, or whether we should just be managing them conservatively or not. So what we do know is that a lot of PDAs in up to 85% of these small babies, less than 1.5 kilograms, will resolve spontaneously without treatment. However, equally, we know that prolonged exposure to a large PDA can increase the risk of developing bronchopulmonary dysplasia and pulmonary hypertension. So there's lots of treatment strategies, and the key ones are kind of conservative management versus medical management versus surgical management. So in terms of medical management, paracetamol is often used. It has the least the lowest side effect profile, but there's less evidence for its efficacy. Ibuprofen has the most evidence for efficacy, but has a higher chance of GI bleeds and AKI than paracetamol. Indomethacin is also effective, although its risk profile is higher than that of ibuprofen, so we wouldn't use that in Leeds. And then finally, surgical closure, which again is a controversial area and requires careful thought and MDT discussion, but is an option. There is a risk of vocal cord palsy, pneumothorax and chylothorax, but there are some babies who benefit from closure. We have to be careful about observational studies. There are some that show higher incidence of long-term morbidity with surgical closure, but we have to be careful of selection bias in those studies, because it may be that those babies had their PDAs closed because they were already so unwell, rather than it being a causal link. There is increasingly the option of catheter occlusion of the PDA. So in Leeds, we would consider this in babies greater than 2 kilograms, and success rates are, if the baby is over 3.5 kilograms, they're up to 100%, but more like 83% if the baby is over 2 kilograms. In general, our guidance from our network guideline is that we should be considering treatment if hypotension is thought to be secondary to the duct, significant hypertension secondary to the duct. If there's evidence of ductal steal and therefore an increased risk of NEC. If there's increasing respiratory support, which is thought to be related to the presence of a PDA, or if there's failure to make progress on weaning respiratory support as expected for that baby. This is a summary of our Yorkshire guideline, which I've already talked about, so I won't go into in detail, but this is the guideline of where we would start treatment. So our first line is ibuprofen unless there is a reason not to, and then we might start paracetamol as first line if we thought the baby was particularly at risk of a GI bleed for other reasons, or if they had already had any renal impairment. So Baby Oscar is a recent trial looking at ibuprofen within the first 72 hours of life. It was rolled out across 32 neonatal units in the UK, and the results were published in 2022, in the last couple of years. So this looked at 653 babies. It was the largest trial globally in 25 years to assess PDA management. and it showed that ibuprofen did reduce the incidence of a persistently open PDA, but it did not improve survival or reduce bronchopulmonary dysplasia at 36 weeks. To summarise, towards the end, the chronic lung disease is significant beyond the neonatal unit, and it's really important that we have a multidisciplinary approach, including liaising with the respiratory team. Closer to term and post-term, they would be considering investigations, and probably more post-term to consider a CT chest or a bronchoscopy unless there was reason to do that earlier, and considering an echo. They're likely to have already had an echo to look for a duct, but we would also want to look at the pulmonary pressures to determine whether or not sildenafil would be beneficial. An ECG would be important to have a baseline to look for right ventricular hypertrophy prior to starting sildenafil. But the mainstay of treatment of chronic lung disease is home oxygen. They would need overnight SATs monitoring prior to discharge. We've talked about diuretics and steroids. They need their nutrition to be optimized, so always should be under a dietitian. And we would give palivizumab RSV prophylaxis. So to conclude, I'm just briefly going to talk about two new studies. So there's the PLUS trial ongoing, which is looking at surfactant with budesonide in babies less than 28 weeks. That has shown no difference in bronchopulmonary dysplasia growth and length of stay. And then the AZTEC trial, which looked at whether macrolides reduce the incidence of chronic lung disease, looking at almost 800 babies across 28 neonatal units, and that showed no increased survival without chronic lung disease. So it is not recommended as routine, although there may be some babies who it's felt that from an individual point of view they may benefit. So to summarise, this case review tool is from BAPM and again summarises an approach to improving chronic lung disease and just gives a list of change ideas that we look at in our units to see how we can improve our chronic lung disease rates. And it just really emphasises how important the whole multidisciplinary team is in managing these babies, and how although pharmacology strategies are really important, they're just one area of management of chronic lung disease. Thank you very much for listening. Thank you very much, Dr. Ivan and Dr. Stella, for your really helpful presentations. And thank you, Jenny, as well. Thank you, everyone.
Thanks very much, Georgina and Jenny, and agree. Thank you to Ivan and Stella. I think between the two presentations, just showing how well we can work together across the UK and Uganda, I think we've covered really everything we need to know about chronic lung disease. We've talked about two different cases. So one was the preterm baby in Mbarara who had infection risk factors and was managed on non-invasive ventilation through CPAP. And then the case from Leeds, again, another extremely preterm baby whose risk factors were invasive ventilation and a PDA. But we've covered the pathophysiology, we've covered how these babies can present, the long-term morbidities, and then finally Georgina has summarised really nicely the current treatment strategies to try and prevent that. And I think the BAPM framework I put in the link in the chat is a really helpful thing to try and get us to address this really difficult condition, because it is so multifactorial in how we approach it and how we treat it. So we've just got a few more minutes if anybody wants to put any comments in the chat, but lots of positive feedback for all of our presenters on such really good, clear presentations. And hopefully Kathy and myself have managed to answer quite a lot of the questions, and thanks to everyone else who's answered the questions for us as well. But again, really good participation. We had over 170 people on this grand round. And again, it just shows a great collaborative approach between the UK and Uganda. So if there's no other comments, I can't see anything else coming up in the chat apart from just lots of thank yous to everybody involved. I'd like to wish you all a very happy Friday and weekend, and thank you so much again for joining.